Hello, fellow zebra hunters. This is Diagnostic Atypia. Please remember, the content of this podcast is meant strictly and exclusively for the purpose of education and entertainment. The information discussed is not a substitute for your own clinical judgment. All opinions expressed on this podcast are exclusively those of the hosts and do not reflect the views of our employers or other affiliated entities. All cases discussed are HIPAA compliant, with key identifying details changed.
Well, I have a question for you, Mike, the icebreaker for the day, because I left you hanging last time. I'm sipping iced coffee here, but what's your go-to beverage for work, or just go-to kind of starting the day ritual for work for you?
I think like a spindrift,
Mm.
grapefruit spindrift. I'm pretty addicted to those. If I told Bruna, like if one day we find out that there's arsenic in spindrift, there's some recall, I'm done for. That's like, a can a day. So, spindrift, if you're out there, please, good quality control. My health and life depend on it.
Oh my gosh, we're looking into getting one of I don't know what you call it, where you can carbonate your own
Yeah,
beverages
yeah,
and
the
like
soda
flavor them.
stream. We have that too.
Yeah, we want one of those. Yeah, Simon has one of those. Our
Yeah.
Simon from residency, and he made us a drink when we were over the other day. And yeah, we definitely need one of those.
Yeah, they're
Lunch.
great. They're great. Yeah, we actually don't use that as much as we used to, since I've developed my spindrift condition.
Well, listeners, you know what to get us for Christmas, okay? Spindrift production. That's all we
And a
need.
soda stream for Andrew.
Yes,
Maybe we'll get a
please.
sponsor from either of those if they're listening. I don't know if they would ever listen to this podcast, but they
One
stumble their
day.
way into diagnostic reasoning.
One day. All right, Mike, I got a case for you.
The time is now. Let's do it.
The time is now. Uh, this case is just so much fun. I'm so excited for you. It's a case of a man in his 80s who I was phoned about on the hospital transfer service. So, as a gatekeeper for hospital transfers, my role is to accept phone calls from docs at smaller hospitals whose patients may require a particular subspecialty procedure unavailable where they're at, or a highly niche subspecialty consultation not available there. So, important for context purposes for this case, this is a patient whose records I had available by EMR, but who I actually never met in person. So this is completely a chart dissection case, okay? So again, this guy is in his 80s. He presented to an outside hospital for a planned colonoscopy for weight loss, now with a BMI of 17, recurrent syncope due to orthostasis, and fatigue. His pre-colonoscopy lab showed a hemoglobin of 6.5. So instead of proceeding with the scope, he was instead admitted to the hospital for transfusion and monitoring. So for his past medical history, he had a TAVR, a transcatheter aortic valve replacement for aortic stenosis. Based on chart review, it seems this has been compensated when the patient was seeing his PCP over the last few months. No signs of decompensated heart failure on their exam. Regarding present symptoms, it seems he was only having very scant bright red blood per rectum per notes without melena. And per notes, his weight loss was of unclear source, hence the plan for colonoscopy as he was due for this. He had no history of known malignancies. He was allegedly tolerating PO at home just fine, so nothing like dysphagia. He was not on anticoagulation or NSAIDs. A recent outpatient iron panel showed normal serum iron, normal TSAT, and ferritin greater than 200. So, getting back to the present, I'll quickly give you a CBC. Had a white count of 5.5, platelet count in the 200s, MCV of 101, and a normal cell differential. And just like in PCP notes, he doesn't have any peripheral edema or signs of CHF on the admission exam. After he's admitted, he is transfused and has an appropriate hemoglobin increase to 7.7 and 7.8 on repeats. He then began bowel prepping for the planned colonoscopy, and on day 2 of admission, he cited, quote, pulling a muscle in his left back and abdomen with associated mild pain. The next day, day 3 of admission, he had an episode of syncope while in the toilet, and a hemoglobin is repeated and down to 7.0. On day 4 of admission, he ends up going for the colonoscopy, which showed no hemorrhagic lesions in the colon, and it was a good prep, it was a good colonoscopy. Post-operatively, he has severe worsening of the discomfort that began in his left back and belly 48 hours prior. And on exam, he has a palpable ecchymotic lesion in that area. I was called at this time to discuss whether transfer is warranted for interventional radiology intervention for a CT scan finding, which I'll show you now and put up on our website.
All right, so listeners, take a look on the website, excuse me, but massive ecchymosis. I'm looking at the flank here, or this is the back, kind of the left flank back.
Yeah, it's like the lateral abdominal wall into the back. Yeah, flank.
Gotcha. All right, and then a CT scan. Ooh, is that a rectus sheath hematoma, maybe? I don't really see R. I was thinking RP
Yeah,
hematoma, but I'm
yeah.
not actually seeing
Mm-hmm.
rectus sheath. Is that what it? Okay.
Mm-hmm. Yeah,
Yeah,
it's
so he
it's
just bled
all
into his abdominal wall, into his, you know, yeah, rectus sheath.
yeah.
Wow. Okay.
Yeah. So I guess question one for you, Mike, is just like big picture, how do you think about bleeding, which is kind of the what's going on with this guy?
Yeah, this is a great case because there's so many little things that you can latch onto, which is cool. Overall, I mean, the first question is there some obvious injury, right? Because, I mean, everybody does bleed appropriately. So if you get hit by a bus, right, and you're bleeding, you don't have a bleeding disorder, you have a getting hit by a bus disorder. So obvious trauma, right? Which actually I should say it can be a tip off, pediatrics, elder abuse, domestic violence, right? If you have bruises in areas that are weird, always should just raise the idea that this person could have had trauma inflicted on them. So that's the first thing. Like that's the appropriate response to trauma is a bleed. Um, it's when the bleed doesn't stop that it's an issue, or when the bleed, in this case, it sounds much more spontaneous, or at least with a very mild or minimal trauma, maybe moving him onto the table for the C scope. But again, that's shouldn't be enough to cause this. And so we're now in that category where we're worried about an actual underlying bleeding disorder. And so, there's a questionnaire that you can ask, BAT, I think, BAT, which I suppose I can share on the website. I don't know all of the things, but it's asking about sort of specific characteristics of a bleed. But honestly, I like kind of just thinking through what is needed to form a clot. So, first, you just need good integrity of the vasculature, of the connective tissue, right? So, again, if you have trauma and it destroys that tissue, then that's why you bleed, and then you have hopefully an appropriate response and clot. But you can have underlying problems with the connective tissue in I'm thinking congenitally, you're talking about, I think the one I think of is like Ehlers-Danlos or Marfan syndrome. There's others. Those are the ones that come to mind at the moment off the top of my head. And then, for him, he's 80, so acquired causes. Um, that's going to be vasculitis, right, can do this. It's an actual damage of the vessel walls. If you have, corticosteroid exposure, right, it thins the skin, thins the collagen. You can have iatrogenic, right, with corticosteroids, but you can also have Cushing syndrome, right? Um, Other things, I mean, amyloid, amyloid can do this. He's 80. Um, and I've seen one case actually of someone, and I actually don't know if this was what it ended up being, but there was like pretty strong suspicion for scurvy, which is vitamin C deficiency. Again, this case has so much to it. He does actually have this like weight loss, and he's getting a C scope for, could he have malnutrition and he has vitamin C deficient? I mean, yeah, maybe. I don't know. And then we move on to, right, like the platelets themselves need to be able to function and clot and aggregate to start that plug, which is called primary hemostasis. Um, and really, it's about, do you have enough platelets and do those platelets work, right? So that's why a CBC is like a huge part of the screen for abnormal bleed, because if your platelets are 8, then, that's the problem, probably. You may have other things, right? You can have liver disease and you can have coagulation cascade issues, but if your platelets are 8, your platelets are 8. Um, then in particular, you can also have platelets. You have enough of them, but they don't work, right? I think the classic one we think of is like uremia, uremic bleeding. Um, or other causes that cause platelet quality issues. NSAIDs and clopidogrel and aspirin, right? All your antiplatelet stuff. And you can also have things that are consuming platelets, right? Like the, DIC, your other MAHAs. You want to probably get a liver panel, Chem7, right? You want the things that tell us about the liver function, the kidney function to some degree. Then you actually need to make the clot, right? And so that's the coagulation cascade that keeps all of us up at night. That really is tipped off by two simultaneous processes. And so you have, I'm gonna see if I can remember these correctly. You have, I think, the intrinsic pathway, which is from that collagen exposure, when the vessel breaks open. And then there's the extrinsic pathway, which I think is from tissue factor. I actually don't remember how tissue factor even gets formed. And coming down the intrinsic, that's your PTT side. That's going to be a ton of factors, right? So I think it's, you know, 12 through 8 or something, obviously not with 10, I think, excluded. And then the other side is factor 7. That's going to be your, PT-INR. It's like your warfarin, right? So that's why, again, the next thing you're going to get is coagulation factors, right? Like the PT, or excuse me, the measures of that, which are PT and PTT, because it may help you localize to one side of that. Um, and yeah, I mean, I think that's kind of the place I'll start. I'll stop rambling here. He has such some of the other things too, right? So he also has a TAVR from AS that can just cause like mechanical destruction of platelets, of von Willebrand factor. So that's like another thing that could be going on here. But I'll stop. He just has, it's a cool case because he has so many little things you can latch on to.
Awesome. Yeah, I can definitely give you some more information. Such a great way to think about bleeding. And while you were talking about the coagulation cascade, I pulled up my notes on this because listeners, we're not hematologists. We don't think about this every single day. Yeah, extrinsic pathway is the PT factors 1, 2, 7, 10. Intrinsic pathway is the PTT factors 1, 2, 9, 10, 11, 12. So we don't have to get into the nitty gritty of that. We can keep going here. It's very complicated to look at it every single time. Okay, so as you pointed out, the CT showed a rectus sheath hematoma. The INR was normal, but the PTT was in the 90s. Again, this was off anticoagulation. Fibrinogen was normal. Reticulocytes were appropriately elevated. A homocysteine level sent in the outpatient setting, which is very similar to the methylmalonic acid, was elevated at 20.5 micromoles per liter, the upper limit of normal being 15, kind of indicating a B12 deficiency diagnosis in the past. There's no documentation of any of this, but to promote discussion, I'll give you a few historical elements to consider. There was no mucocutaneous sites of bleeding, for example, no epistaxis, no hemarthrosis, both at present and in the past, and his BMP and his LFTs were unremarkable. On the scan I showed earlier, the liver does not appear abnormal on cross-sectional imaging. However, actually present in the chart is documentation that prior to admission, he had apparently had a fall onto his left ankle, which was markedly swollen, very tender on weight bearing, and which had an overlying firm ecchymotic lesion consistent with a hematoma, it sounds like. They got an X-ray, it showed no fractures, but did show extensive subcutaneous fluid and severe erosive arthropathy of the MTPs and ITPs, which I'll show you and the listeners on the website. Again, these erosions of the MTPs and ITPs.
Yeah.
And when you look at prior to admission labs, there's a CRP that is high at 14.4 milligrams per liter and an ESR that is high at 27 millimeters per hour. Also, when you dig even deeper into his chart, you unfortunately can't read the clinic notes, but you do see various imaging reports that are interesting. I'll list them off to you. So, first are two images from just a few weeks ago. CT upper extremity with contrast. Reason for study: progressing right upper extremity swelling and ecchymosis. Conclusion: Diffuse superficial soft tissue edema consistent with cellulitis or contusion. Then there's a duplex of the same extremity. Conclusion, no evidence of DVT. Then next is a scan from several months ago. MRI thigh without contrast. Reason for study, fall with left proximal femur pain and inability to weight bear. Negative hip x-rays. Conclusion, suspected intramuscular hematomas within the proximal vastus lateralis. And I'll stop here.
Want to clarify one thing. So you had said which factor was elevated, or sorry, which was it PT or PTT that was elevated again?
PTT, INR normal.
INR normal. Okay, thanks. Um, okay, so what I'm hearing is that this is an elderly gentleman with recurrent soft tissue hematomas, sort of out of proportion to traumatic event. And you mentioned sort of, Andrew mentions, no mucocutaneous bleeding, right? So when we think about platelet disorders, you're going to think more about mucocutaneous bleeding, excuse me. And so people will say like when I brush my teeth or during a tooth extraction, they also get like a petechial rash, right? They can just kind of bleed into their skin. But these deep bleeds into the, muscles, hemarthrosis. I don't know what to make of this erosive changes. I don't know if he's bled into those joints before, and that's what's happened there. I'll have to kind of percolate on that. But I'm hearing a defect that localizes really to the coagulation cascade itself, rather than maybe upstream in the platelets. That's just my initial thinking. And then when we think about, the PTT, that's going to be the intrinsic arm, if I'm not mistaken. And so that's going to be your sort of many factors that of which, it's 12 through 8, I believe, without 10. So that's going to be your collagen exposure side. Um, and so the question, I guess, would be, does he have a deficiency of one or multiple of these factors? Does he have an inhibitor of one of these factors? Since his PT-INR is normal, I don't think that's going to be in the common pathway, which is like the, factor 10 down. And, it's I was actually, as you were speaking, I was kind of reflecting and realizing I went for the zebra of scurvy without talking about vitamin K deficiency, which would be much more common. And you could also see if he has malabsorption. He has B12 deficiency, it seems. So it seems like there's some malabsorption component to maybe his weight loss, but that should really be an elevated PTINR. So I don't know that that's what this is. And so, I mean, if the collagen itself is getting exposed too easily, then also that's something, right? So, if you have vasculitis, if you have a collagen disorder, which again I think is more congenital, but you need something that causes easy tissue damage, right? So it's not actually the bleeding. So I suppose that could also be this, since that's that side of the pathway. I think amyloid can do that. He's the right age. I didn't hear steroids. Steroids can do that. Um, I think that is actually the mechanism of action of scurvy. I don't know why I keep coming back to that. He's doesn't
Mike's been
sound like a
thinking of
pirate.
pirates lately. Yeah, Mike, you
Yeah,
been playing
yeah, I've
any
been thinking of
pirate video
pirates.
games?
So yeah, that's the zebra, I suppose, that I need to get back to the horse pasture. So that's sort of my initial thoughts. I think that the next step for me would be to actually send the factors themselves and the activity levels, and then do a mixing study. And I think that those things would help us know, are there deficiencies, and then if there's no deficiencies, is there a problem with their function? I'm not really hearing a need to do as many of the platelet tests, like, von Willebrand's really, common. He could have an acquired deficiency from his, if his TAVR's not working well, but, so I know that stuff would be sent, because it's just going to be like an order set, I'm sure. But I think if I had to be judicious, then I think I'd probably look at the factors. I'm guessing that's kind of where I'd go next.
Oh yeah, yeah, yeah. You could send so many things. Like let me just pull up my note on out of proportion spontaneous hemorrhage really quick. And you could test for all of these things, right, listeners? But you're really kind of taking the syndrome into account here. And you're saying there's no mucocutaneous bleeding, but there's more of these like deep space sites and also out of proportion the trauma kind of sites and like what does that inherently tell us about the kind of the bleeding disorder. So I think that's why is like all right, there's the PFA 100 test. This is for like qualitative platelet defects. Has a very high negative predictive value for qualitative platelet defects. So can be sent only if there's low pretest probability for that defect. So it sounds like if you want to rule out a qualitative defect, that actually may be worth doing here. If there's a high pretest probability for a platelet defect, that should be followed up with platelet aggregation study, genetic testing, and electron microscopy. These are for these like storage pool disorders. So there's like so much you can send for this stuff, and I'll just give you exactly what you wanted because I think that's what's relevant here. So you wanted a mixing study. That was performed in the outpatient setting, it turned out, as this was kind of already known. Um, the INRs, again, were normal, so I won't mention that part of the mixing study. But the PTT premixing was prolonged at 103 seconds, and the post-mixing time was still prolonged at 56 seconds. So it did not fully correct, it only partially corrected with the addition of pooled plasma from a healthy person. And several days into his rectus sheath hematoma presentation, he then developed on the contralateral side this subcutaneous hematoma, which I'll send you and also go on the website. This one, there's nothing in the chart like, oh, I bumped my body, I hit something. There's nothing about that. But this thing formed. For final clues to wrap up this case, I'll give you one more interesting finding from the chart dissection, and this is going to be all you need to make the final diagnosis, which may not be just one diagnosis. Progress notes from oral and maxillofacial surgery. Quote, extraction of remaining teeth uppers and lowers and placement of two implants. And that's the final aliquot for the final diagnosis.
So the final aliquot is that he has well, sorry, his final aliquot is that he has tooth uh extractions and implants.
Uh-huh.
So, okay. And sorry, it's the fact that it's the implants, not the fact that he had some horrible bleeding during that procedure.
Uh, I'll say his teeth were loose.
His teeth were loose. Hmm. So that, I mean, that really makes me think about a tissue defect, a collagen defect, or something with the actual tissue. Um, wow, I don't know that I have any illness script for loose teeth. So I think I'm just going to think about an illness script for bad tissue. And I think I've mentioned kind of a bunch of it, right? So he doesn't have iatrogenic corticosteroid exposure. I don't think he has what I'm hearing is Cushing syndrome. I generally don't lose weight. Um, I do feel like I keep saying amyloid. He is old enough. We know that that can infiltrate tissue. Um, so can no, I want to say that syphilis can do this, but I don't think that that's right. That does more nerve issues. And then I suppose scurvy still. I suppose scurvy still. So that, yeah, I guess you know, I don't know if just like also just malnutrition, maybe he's lost so much muscle and tissue mass, maybe that he just hasn't have a lot of room in there. But that is total hand waving. I'm going to say it's going to be a defect with something to do with the collagen or the tissue. I will be honest, I don't know why that would cause a prolonged PTT that happens not just in the body, but also in the mixing studies, right? Because that would suggest that there's still a defect in that side of the coagulation cascade, and that shouldn't matter if if you would need two processes here. You would need bad tissue that exposes collagen frequently, but you would also need to have some defect in that arm. So, I'm going to say that he maybe has a factor deficiency that's related to malnutrition, but I don't know that I have a way to connect that. But it'd be a deficiency, right? Because it doesn't correct with mixing. I might have that backwards. Um, I got it backwards. I got it flipped around. Yeah, yeah, yeah. So you could have an inhibitor. He could have an inhibitor then. which I don't, again, I don't have a NL script for that, or I don't have excuse me, I don't have a good thought. But I'm going to stop there before I talk myself into any further rabbit holes.
No, you got it. You got it. And you called it from aliquot number one, too. So I'll give you the reveal now. So a vitamin C level was sent and low at zero point 0.1 mgs per deciliter, the lower limit of normal being zero point 0.2, confirming scurvy as a strong predisposing factor for hemorrhage out of proportion to trauma at multifocal sites, as well as seemingly inflammatory arthritis, severe anemia, and dental disease. Additionally, he was found to have a factor VIII inhibitor as the cause of his prolonged PTT, confirming an acquired hemophilia as another player in this patient. So, for the first half of teaching, I thought I'd start with a quick overview of the various manifestations of scurvy. So, I think it's what it's most well known for is what Mike talked about extensively, its impact on organs that require collagen. So, as a cofactor for the reaction that facilitates collagen cross-linking, vitamin C is necessary to keep our connective tissue strong and disease-free. So, anywhere there's collagen, scurvy can cause issues. So, blood vessels, type 4 collagen in the basement membrane, type 3 collagen in blood vessel walls. Disorder here results in vascular fragility prone to rupture, with the overarching presentation of vasculopathy being that of kind of out of proportion hemorrhage to minimal trauma, like Mike talked about over and over again, as well as spontaneous intra-abdominal hemorrhage events. There's actually a great case on the St. Paul's Morning Report podcast called, quote, exploding organs that refers to the traumatic intra-abdominal hemorrhage you can see in various vasculopathies. A tangent aside, another strange location for bleeding and scurvy is the periosteum, with subperiosteal hemorrhage also being due to capillary fragility. Collagen is also important for the musculoskeletal system. Non-specific arthralgias, bone pain, and myalgias often prompts referral to rheumatology. Some of these pains can be due to microscopic defects you can't visualize on imaging, but others are image positive, as in the case of inflammatory arthritis, intramuscular hemorrhage, as in this case, and bone findings mimicking osteomyelitis. So it's actually on our osteo mimicker schema. A more subtle change that can be seen on MRI is also diffuse subperiosteal edema. The remaining scurvy manifestations are not due to collagen issues, but actually biochemical issues because vitamin C is a cofactor for catecholamine and nitric oxide synthesis. So, to this end, some very strange manifestations of scurvy include pulmonary hypertension and orthostatic hypotension, the former issue being due to decreased nitric oxide, and the latter issue being due to impaired catecholamine synthesis. Less
Is that his recurrent syncope?
Potentially. I mean,
That's
he's also
crazy. That would be
he's
crazy.
also very anemic. You know, I never met this guy, but it's possible. It's on the differential for him for sure. He was very anemic, but also he was very vitamin C depleted. Anemia is present in up to 75% of cases and is usually normocytic unless other deficiencies are present. So in this case, he was B12 deficient. It was discovered, but also anemic kind of despite that through therapy, it seems. Leukopenia is also not uncommon, but wasn't present in this case. And then the mechanism of anemia is unclear, but some have proposed that this interferes with iron and folate metabolism, or it can cause gradual GI blood loss of vascular ectasia, which we already talked about, and chronic hemolysis, which I'm not so sure about. And finally, elevated ESR and CRP, like in this case, is not uncommon, and another reason scurvy often presents to the rheumatologist. Okay, so part two of teaching is more about broader clinical reasoning principle that derives from the question, why? Like, why did this patient present now so dramatically? So we were talking about this issue over at CP Solvers recently, and the idea that while we're very good at finding provoking factors for acute disease presentations, there's not infrequently something else required for disease to manifest. In other words, what is the precise substrate in this patient that led them to be susceptible to the trigger of disease? So, put into a formula, you can visualize this as disease equals trigger plus predisposing factor. So in this case, the bowel prep with Valsalva mediated intra-abdominal pressure was the trigger for rupture of fragile blood vessels, with predisposing factor being scurvy related vasculopathy. And interestingly, the presence of a superimposed factor inhibitor is probably why this patient not only bled, but why the patient bled quite impressively with huge subacute hemorrhage and a very large rectus sheath hematoma. So in other words, putting this back into the equation, disease one for this patient equals bleed severity not specified, Valsalva plus vasculopathy. Disease two equals bleed severe quantity, severe phenotype, vasculopathy plus factor inhibitor. So that's kind of the overarching kind of concept I took away from this. And then for final reflections, where do these nutrient deficiencies come from? You've kind of pontificated on this already. It's not clear. They got an EGD with duodenal biopsy. It didn't show any celiac disease. And for his dietary history, this is all I could find. Quote, he states his diet is increased, but he's still consuming a notable portion of food. His breakfast yesterday consisted of sausages, hash browns, and toast. His lunch consisted of a lobster roll, fresh caught lobster that he caught himself. His dinner consisted of steak tips, mashed potatoes, and string beans. So I think the only thing in there is the string beans, and if he cooks down the string beans, probably not much vitamin C in there. And then the final question that the listeners are probably wondering, did I accept the patient for transfer? Interventional radiology declined the patient for transfer and said do compression. I told them send a vitamin C level, and this is what I found a couple of weeks later. That's the case, Mike. What are your reflections? You were on it. You were on it from aliquot number one.
Wow. Wow. You got it. You asked them to send the vitamin C over the hospital transfer triage call. Look at you.
Just scheming in my hospital workroom.
My reflections. Um, well, I think I was expecting this to be something in the coagulation cascade, platelet issues, but remembering that what triggers all of this is tissue issues. To start, I think most of the time appropriate, but in this case, kind of inappropriate bleeding out of proportion because the tissues themselves are the problem. And then I suppose, that you can have multiple disorders at the same time. And clearly, I need to go relearn the mixing study. But no, that was a great case, and I think he's like I'd said, I think twice already. There's just so much to latch onto in his case, and so it's easy to go down different paths. The history here was pretty key.
Yeah, yeah, great work, man. You were on it from the beginning again, and we're coming up on the hour here. It's gonna boot us out. Take care, everybody.
So yeah. This has been Diagnostic Atypia with Doctors Andrew Sanchez and Mike Arcieri. The show is produced by us with the help of Podcastle. Our intro-outro comes from the album To the Surface by pianist Lawrence Fields. If you enjoyed this show, consider subscribing and sharing our episodes with others. If you have your own atypical diagnostic journey to share, please reach out to us dx.atypia@gmail.com. We'd love to discuss it with you, and we welcome medical students, residents, and even seasoned attendings. Happy zebra hunting. We'll see you next week.